Mike Gibson, Rich Wright, coming to you live from AHA 2023, and we're talking about Acoramadis, a drug used to treat amyloidosis, cardiac amyloidosis. Rich, why are you so passionate about this? Talk to us about the kind of bench to bedside approach that happened here.
Yeah, thanks, Mike. Well, having been in the heart failure field for many years, it's been particularly exciting for me to see that people who make observations and the bench researchers can translate maybe nature's experiments and observations into clinical tools that we can bring directly to the patients and improve them. And Acoramadis is really such a drug, where you have an observation that there's a disease that we previously had no treatment for, and frankly was partly underdiagnosed because of that. Obviously, doctors and patients aren't that excited about something where you make a diagnosis and have no tools to help. But once you had the observation that there were people that had mutations that actually offered protection against developing the clinical syndrome of transthyretin cardiac amyloidosis, and exploring what about that mutation made a difference, and then using that observation to design a molecule that could mimic these people that had protection by a beneficial mutation really is pretty stunning.
Now, Rich, is there Mendalian randomization data about that protective mutation?
Yeah, so obviously there are different forms of transthyretin. Most of the patients I see have wild type, and of course we don't know what causes wild type. Why is it that a purportedly normal transthyretin molecule misfolds and gloms up the system with the problem that people get with amyloidosis? We don't know that, but nature's experiment of people that have mutations that cause the glue that holds the molecule together not to be there, and then the molecule falls apart. And then you have these other people that have that deleterious mutation, but also happen to have a beneficial mutation that then allows them to avoid having the clinical syndrome of amyloid. That's a
Do
pretty
they have better outcomes, that last group?
For sure, they do.
Wow.
There's no question. They don't develop what you'd expect them to develop. If you have a mutation that's going to lead to the variant form, the mutated form of amyloid, you probably have a 50% chance of getting clinical amyloid. But if you have the beneficial mutation, you don't go down that pathway. And that was the sentinel observation that led to say, what's different about those people, and can we employ modern science to design something that will offer such similar protection? And that indeed has been achieved with Acoramadis.
Yeah, my son, I'm a clinical trialist, and he'll ask me, "What are you up to, Dad?" And I'll say, "Well, we're doing a trial. It's going to have 50,000 patients with factor 11, as an inhibition." He just always rolls his eyes and says, "Dad," he's a quantitative genomicist. He says, "Dad, why are you doing this? I mean, nature's already done the study, and will walk me over to the UK Biobank." But this is, in an efficient, appropriate way, right, to use genetics to already have the answer that nature's already provided to us. So very exciting. What about that early part of, the journey for the molecule, linking those protective genetic mutations to, the biochemistry? Talk to us a little bit about that if you can.
Yeah, so obviously, if you can mimic nature and glue together, so the fundamental problem in transthyretin is that, as people hopefully know some about this, it's produced as a monomer, but it circulates as a tetramer, and in its natural form, in its biologic transport form, where it's transporting molecules around the bloodstream, it conglomerates into a tetramer, and those molecules have to be glued together, basically. And what Acoramadis is the analogy I employed is that this is like super glue, where you take the molecule and you glue it together so that it doesn't fall apart and then lead to the problems that people get with amyloidosis. And the remarkable thing about the clinical data that you've seen is that this benefit appears to appear very quickly. I mean, previous trials have shown that the lag time, similar to lag time when you give statins, for example, to improve somebody's outcomes for coronary disease, the lag time may be 12 or 18 months. In this particular trial, the Tribute trial, 3 months later, the people were doing better doing better by keeping them out of the hospital, for example. Later, there's a signal for mortality benefit, but in terms of clinical benefit, it's pretty quick, which is unique in the world of amyloidosis.
It is. And can you speculate? You may not have presented data yet, but can you speculate about maybe there's not just cessation of new amyloid deposition, but could there possibly be regression of existing amyloid deposition?
Yes, we know that can occur. It has occurred in nature, right? So people do have enzymatic ability to clear amyloid. The problem historically has been that the accrual rate of amyloid is faster than the dispersal rate of your enzymes chewing up the amyloid that's there. So you could certainly speculate that if you completely turn off deposition of new amyloid, that the body's own system, be that through antibodies or enzymatic action, can get rid of amyloid that's already been deposited. That would be the holy grail in this field.
Yeah, it's a little bit like thrombolytics there, or antiplatelets and other drugs that stop the coagulation cascade and allow your body's own endogenous lytic system to kind of dissolve things. So similar
Right, and that's a
here.
very good analogy because obviously some clot takes a long time to dissolve. But there have been, if you look at amyloid centers, there have definitely been cases, I've seen them myself, where people seem to regress spontaneously. And so it's possible that if you could totally turn off amyloid production, then you're right. Maybe you would see nature heal these amyloid deposits.
Right, right. And of course, there was the few years of follow up here, but boy, play this out for 10 years.
Yeah.
The
And
absolute
obviously nobody's been on Acoramadis for 10 years, the
right.
molecule developed that period of time. But this is a long time frame. And if you look at the curves in this attribute trial, placebo treatment versus treatment with Acoramadis, the curves continue to diverge through the duration of the trial,
Right.
30 months or so. But you're right, if that were to continue, and a significant percentage of these people had total stability or even improvement in things like exercise, for example. So one could postulate that over a longer period of time, you'd even see a greater benefit.
Yeah. Exciting stuff. Well, Rich, thanks for chatting with us. Thanks for putting all the pieces together. And thanks to all of you for joining us here from AHA 2023.
Mike, my pleasure. Good talking.
Thanks.